Multiple sclerosis patients often have relapses, especially in the early phase of their disease. And these attacks can be heterogeneous, so people could have either optic neuritis, sometimes transverse myelitis, which are manifest by different neurological symptoms. And we define complete recovery as a complete return to their prior function after the relapse. Generally, we measure this about 6 months later, anywhere from 6 to 12 months later. And so someone with incomplete recovery from relapses does not have a return to baseline. And we can measure that using the EDSS disability score or a functional status score. We've looked at this in our CLIMB study, and what we've found so far is that incomplete recovery is associated with older age. And that seems to be consistent between different studies. We haven't found many other factors so far that are associated with incomplete recovery, and that is another area of investigation that we're now embarking on. We know that as you have multiple attacks, then there can be more neurons that are damaged in the CNS, and that might also contribute to increased disability and poor recovery from relapses. However, when we looked at patients who are in the early phases of disease, both younger as well as older patients who really were around the time of their first attack, older patients still had incomplete recovery more often than younger patients. So younger age does seem to be beneficial for better recovery, and this is something that we're now investigating. What has been borne out in studies is that early medical attention is important. If steroids are warranted, these might benefit both relapse severity as possibly recovery as well. And this is what I generally advise for my patients, a course of IV steroids at the time of a relapse. And then afterwards, physical therapy, supportive therapy, and then anything that promotes wellness, including appropriate diet, exercise, cessation of smoking. These likely all affect relapse recovery. In general, we need to pay more attention to wellness throughout the MS disease course, but especially around relapse recovery. And physical therapy, occupational therapy is a small part of it, and then adding on these other factors are probably going to be important. So what we also know about relapse recovery or incomplete recovery is that it does predict or associate with more disability accrual and secondary progressive MS down the road. So it is important to address this early on, and I think also we should think about this as a biomarker. So someone who has had incomplete recovery might be a better candidate for more potent treatments, because we of course want to prevent future attacks from occurring and prevent disability accrual down the road.